Good evening, everyone. Welcome to this wonderful session of critical care review of 2023-24. My warm regards to all my seniors over here who have been guiding us in each aspect in the ICUs. Today, in this session, we are going to discuss about the surgical aspects, especially the abdominal surgeries regarding minimal access, robotic, as well as general surgery, the components involved in it, and a few review articles which are related to these fields will be coming across. So the first one is the use of non-invasive ventilation in the perioperative period. So this was a article which was published in the British Journal of Anesthesia and also put forward in Oxford review articles in 2016, which takes into consideration the use of non-invasive ventilation in the perioperative period. So the need for this review study was that maintenance of adequate perioperative respiratory function is very important for the safe delivery of anesthesia as well as for uneventful recovery thereafter. It basically aims at optimizing the tissue oxygenation, which preserves the organ function, which helps in the wound healing as well as the protection of surgical anastomosis. Knowing the physiological changes and the perioperative pulmonary complications following these surgeries and optimizing the plan of management accordingly it becomes a very important aspect in management of patients and reducing the perioperative mortality as well as morbidity. The use of perioperative non-invasive ventilation reduces the incidence of post-op complications, high-risk surgeries, as well as for patients with significant respiratory disease preoperatively, thereby reducing the post-op complications. Unfortunately, there is no clear guidance which exists regarding the optimal timing of the use and pressure settings to be utilized in the perioperative non-invasive ventilation. So this review was to aim to summarize the biological rationale and the current evidence behind the NIV use in perioperative period. Because if you consider in general patients undergoing abdominal surgeries, it's a vast spectrum. And not all the patients will have just the abdominal complaints. They will have some systemic components also. So it's very important to take into consideration the patient as a whole rather than just with the presenting disease. So the benefits of non-invasive ventilation, which were debriefed over here, was that it provides alveolar recruitment, improves the oxygenation as well as the CO2 clearance, reduces the incidence of basal atelectasis, preserves the lung volumes, reduces the work of breathing pre and post-operatively, maintains a patent airway, reduces the extravascular lung water as well as pulmonary edema, reduces the left ventricular afterload and prevents the cardiovascular complications, enhances the left ventricular performance and avoids the complication of invasive mechanical ventilations. So this was a flowchart which was provided after the study, which takes into consideration not only the post-operative care, but the care begins pre-operatively with the evaluation and planning, along with the appropriate environment selection for these patients, as in high dependency units or in the ICU. A few patients who were studied who were on NIV or CPAP pre-operatively were also taken care of in the wards. So it becomes very important to select the patients who can go post-operatively into the wards or who require high dependency units or ICU management. The special subsets of these patients which require special mention were the patients who are undergoing major abdominal surgeries, wherein more than 50% of the patients usually experience hypoxemia post-operatively. Patients who have sleep disorders such as obstructive sleep apnea. The study proved out a point that 70% of the patients who are having obstructive sleep apnea were undiagnosed perioperatively. So it is very important in the pre-op evaluation to diagnose the component of obstructive sleep apnea so that preoperatively they can be optimized and the postoperative complications can be reduced. And especially the patients who require high amounts of anesthetic or analgesic drugs intra as well as postoperatively. And it also depends on the duration of the surgery. In the conclusion of this study, it was pointed out that it is difficult to demonstrate a mortality benefit with non-invasive ventilation usage in elective surgical populations due to a very relatively low baseline risk. Although there may be a underlying survival signal in selecting a high-risk patient group. It has shown to improve, to have other important patient-centered benefits, which includes the prevention of post-operative pulmonary complications, as well as reducing the critical care and hospital length of stays. The perioperative non-invasive ventilation care should be delivered in an appropriate environment with a trained staff and a close monitoring, preferably in the ICU or in high dependency units. The surgical complications, which often are signified by respiratory failure, must be identified before the non-invasive ventilation is commenced, and invasive ventilation at no point of time should be delayed if the NIV fails. But with a heterogeneous patient population with a greatly differing risk profiles for respiratory compromise and presenting for a largely variety of surgical procedures, it is very important that the approach needs to be individualized to every patient for the respiratory management as well as preventing the complications. I would request Dr. Paresh to take this topic forward, and I'd like to discuss it with the expert panelists regarding the same.
Yeah, hi. Thanks, Dadivya, for that presentation. Firstly, I thank the critical care team, Dr. Rahul Pandit and his entire team for organizing this event and making me a part of it. So basically, I will quickly go on to the, just sharing my slide. Okay, it's visible?
Yes, it's visible.
Okay, so so here in this review, we're basically trying to see what have we kind of planning to come up in the from 23 to 24. What new changes are we planning to implement, or are we already following the same? And is there scope for further changes now? So that's the team. We already been introduced. So it's directly moving on. So for Dr. Lakdawala sir, how common is OSA in your bariatric practice? And is there any role of pre-operative optimization from the respiratory point of view, keeping the bariatric thing in the mind?
Thank you, Paresh. Hello, everybody. Well, as you know, that majority of my patients will have a BMI of at least anywhere above 40. And once the BMI increases, the chances of OSA does increase. So if you look at our profile of patients, you'll have at least 40 to 50% of those patients with OSA. However, less than maybe 20% of these patients are already using a CPAP or a BiPAP or whichever NIV method of optimization preoperatively. Fewer, around 30% of these would have done sleep studies, and most of them are not even aware. It's only on routine history taking that the family members will say that they have a lot of snoring, and then we do sleep studies and we pick up latent OSAs. The symptomatic OSAs, as the BMI goes, in all those patients who erstwhile we used to call super obese group, that is above 50 BMI. Now we've stopped calling them the super obese group, but anyone above the 50 BMI group, I think it's as high as around 70%. And that's where preoperative optimization is very, very vital because anesthesia risks remain much higher. As we do know that even with the latest drugs of anesthesia, a lot of sequestration happens in the fat of the individual, and therefore a lot of them might need perioperative monitoring in the ICU if they've got severe sleep apnea. Paresh?
Perfect, perfect. So what I can gather is the awareness of sleep apnea is increasing in the bariatric group as well, among the laymen as well. And the anesthetic are supporting us in kind of changing their bit of management, if I'm not wrong, when it comes to these OSA-based bariatric patients.
Yeah, we always prefer referring it to a sleep specialist or to a chest physician and optimizing these patients. However, a lot of these patients, because they've never been told that they've got severe sleep apnea, are quite reluctant to use CPAP or BiPAP at home. and they're just not comfortable with the concept of using these machines, and therefore sometimes it becomes a real challenge. And PFT does not really help because, as we do know, a lot of these patients have a combination of restrictive and obstructive lung disease, right?
Perfect.
So the challenge remains as to how to manage these patients. The drugs have got better. We don't use any kind of sedative painkillers in the post-operative period. So those are the advantages and the precautions that the anesthesiologists use.
Well, that's probably one take-home point. The awareness is increasing, and sleep apnea refer to a sleep specialist more. So again, so one more thing: do all pediatric patients end up in the ICU in the immediate post-op, or you have some selection criteria?
Luckily for the ICU team and for us, hardly any percentage of patients land up in the ICU. But the ones who do remain a real challenge. They are very, very difficult to manage because they've got a host of issues. They don't only have sleep apnea, they also have a host of diseases like type 2 diabetes, maybe right side heart failure, maybe left side heart failure. A lot of them have kidney disease and various other things, hypertension, dyslipidemia, and all. There's always a risk that if they're not mobilized well enough, that they can throw in an embolism as well. So it's a huge challenge for both us and them to manage. I think that less than 1% of our patients luckily go to the ICU because most of them are optimized before surgery. The ones who go to the ICU are those people who probably need monitoring at least for a night and with severe sleep apnea. Those who are septic and come in with a leak post-operatively, or those patients who have a high creatinine, and pre-operatively only we know that we are going to be putting these patients for observation in the ICU, or a cardiac illness. So very, very rarely do these patients, however, whatever their weight is, whatever their BMI is, usually they don't go to the ICU. We want them mobilized soon. But when they do go, it takes the best of both the sides to manage these patients.
So probably, again, pre-operative optimization helps you decrease your ICU admissions, if I can put it that way.
Yes.
Perfect. Now, for Dr. Santoshi and Dr. Saumil as well, pre-operative nutrition management, has that changed? Santoshi, you can take it first. Has that changed in your practice over the last couple of years? Do you still keep them fasting? Do you load them with something, or?
Yeah, thank you, Dr. Rahul and his team and Paresh. Seems like a good session. So coming to your question, so in urology, we keep getting different sorts of patients. So those who need some kind of bowel preparation or bowel care, and the others are where we just expect that they might get into paralytic ileus. But the possibility of developing paralytic ileus with usual urology patient is quite low. The only surgery where we get into bowel situation is when we are doing radical cystectomy and urinary diversion. So basically the preparation for these patients is we just put them on the liquid diet a day before, and picoprep just in the evening. We don't dehydrate them, we hydrate them well. And we have an ERAS protocol, which partly we follow it here, which involves basically recovery of early bowel movement. And in order to do that, we keep the opioids actually out of our prescription chart, and early removal of Ryle's tube. We do give them some stimulators like chewing gum. Patients who are smokers, we can give them nicotine supplements, and generally within 48 hours, we expect that their bowel function should recover. Now, this is for the cystectomy patient. Those who are undergoing like prostatectomy or nephrectomy, all these procedures are now done robotically, or most of them, I should say, and there is some bowel handling. But what we have observed is as compared to the open procedure, the recovery of bowel movement with robotic procedure is really quick. And I'm sure even in laparoscopy, you would be experiencing the same thing. So with all these situations, I think minimal invasive surgery is way to go. Even if we do bowel handling, the bowel recovery is quite quick. So nutritional imbalance, we don't see it that often in these patients.
Yeah, I mean,
I
that's
don't know
what,
whether that answers your question.
yeah, that's what the ERAS proposes, the minimal access surgery is
Correct.
kind of a component of ERAS as well. So,
Correct.
Somil, can you take this question about preoperative, any role of carbohydrate loading diet in preoperative era, if you have recommendations and practices on that?
Yeah, thank you, Paresh. Thank you for the moderation. Good evening to all. Thank you to Dr. Rahul and Ketan and the entire ICU group to bring this together. So yeah, coming to nutrition management for major abdominal surgery, uh, when one does perform major abdominal surgery, one very often sees that particularly patients with upper gastrointestinal or hepatobiliary cancers or even colonic tumors are nutritionally pre-depleted. They have got hypoalbuminemia, they have been anemic for a long time. They do run and they generally have had a GI dysfunction leading to nutritional failure as they come in for these kind of major operations. It is difficult to obtain complete nutrition equilibrium, so to speak, in these patients. We generally, in most instances, are not able to achieve absolute correction because the fundamental cause remains uncorrected before they have a corrective surgery or resectional surgery. But to some extent, we are able to bring in alignment the fluid electrolyte balance. You could possibly give them a preoperative albumin or a little bit of TPN or sometimes even nasogastric or nasojejunal feeding to make them ready for an operation. Post-operatively, the emphasis always is that you try to restore enteral nutrition as quickly as possible. In most instances, one should be able to commence nutrition by mouth orally within about 48 to 72 hours. That's what most ERAS protocols would suggest. And even in patients who had conventional open surgery, you could still follow this dictum that if the patient is otherwise doing well, the drains are clean, hemodynamics are okay, abdomen is soft, you could start gentle oral feeding within the first 48 to 72 hours, even after major upper gastrointestinal surgery. Where it is not possible or where there is a doubt, you could always use TPN either to supplement the oral nutrition or enteral nutrition, so to speak, or to substitute. Yes, I think with ERAS and using minimally invasive methods, the use of carbohydrate loading within the concept of an ERAS protocol does have its obvious benefits and should be used if the patient if there is a patient on whom it can be done.
Perfect. So again, everybody emphasizes the same thing. Proper nutritional management, early recovery, enhances early recovery as the important part of this, and that's where I guess we all are pushing towards ourselves. Santoshi, if you can take this, robotic surgery decreases post-operative complications. Do you agree with this? And if you can enumerate few of them,
Yeah, so I think you can rephrase the question. Robotic surgery decreases post-operative complication in the right hands because any surgery, I think, has its own complications with limiting your skill set, because of course, as earlier, I think Dr. Atawar was also mentioning about if you do more number of surgeries, of course, you have been given a godly kind of status where you have got the right skill set, but that's not true even with the robotics. Robotics, we have seen people who have done thousands of surgeries and they do have a number of complications. So, but by and large, yes, coming to your question, I think yes, there is definitely reduction in the complication rate. So just to give you simple things, why patients get recovered early after robotic surgery or minimal invasive surgeries, there is less need of painkillers. So the possibility of having any renal related compromise will be reduced if you're just managing these patients on simple paracetamol. The need of antibiotics will be also reduced. The incision is small, the scarring is less, the early recovery of bowel movement. The vision what we get in robotic surgery is 10 times magnified, and as a result of that, even the smallest blood vessels could be identified and duly cauterized. So we tend to use more and more of bipolar cautery or diathermy during this surgery as against monopolar, which also reduces the surrounding tissue damage. So overall complication rate comes down with robotic surgery. Now, if I compare a specific surgery like robotic prostatectomy, which is the most commonly done surgery in urology nowadays with robotic gear, then you can see the potential complication of bladder neck contracture, because in prostatectomy we have to remove the prostate and rejoin the bladder with the urethra. Traditionally, when we used to do this open method, we had to do hand sewn suturing of the vesicourethral area. Now, the limitations for that were two. The one biggest limitation was you had to go behind the pubic bone, and the access to that area is extremely difficult for surgeon and his assistant to take those sutures. And secondly, the biggest drawback was all those stitches used to be interrupted sutures. You could not take continuous suture. Now with robotic, the area has become easily accessible. And secondly, we can take a continuous suture, which almost makes it a watertight kind of a suture line, which reduces the possibility of urine leak. And in turn, it reduces the possibility of bladder neck contracture or bladder neck stricture. So that has drastically reduced from 10 to 12% in open way to less than 1% in robotic surgery. So I think the list will go on if I keep on enumerating different benefits of reduction in the complication rate of different surgeries. But yes, that is a by and large, I would agree that it is definitely reducing.
Sure. We discussed about respiratory optimization, as I'm sure Dr. Lakdawala has been doing for his patients. Do you also refer them? Do you have something kind of respiratory optimization prior to surgery? Because of the steep head low position, what we give them during your surgeries. Do they need any optimization or otherwise?
So generally, I don't specifically send them for any respiratory optimization unless the physician fitness, which is done well in advance, and the anesthetic fitness has shown any concern, then only I will specifically tell them for the respiratory optimization.
Perfect. So that's the point.
But we always tend to.
Yeah, that's the point. Perfect. The pre-anesthetic checkup, that's very vital, which happens well in advance, so that the anesthetics are taking care of it, well before time.
Correct.
Dr. Lakdawala, for yourself, post-operative leaks, is there a change in how we manage them, or the kind of catching them early or early interventions? Do you think something has changed in your practice?
I guess any management of any leak is very, very vital. The earlier you pick up, the better is the management. Then you categorize them into the criticality of the patient. For example, if you have a minor leak, which is well controlled, and the patient shows no signs of sepsis, patient is tolerating feeds, then you monitor the patient with probably serial CT scans or X-rays or serial blood reports. And if the patient is not going to any critical illness, then you continue the nutrition, improve the protein outcomes, and then that will become better. Let's say it's a fistula because of the leak. Is it a low output fistula? Is it a high output fistula? Then that becomes important. If it's a high output fistula, the most vital thing is optimize the patient and take the patient up for surgery as soon as possible before the patient deteriorates. If it's a low output fistula, again, improve nutrition, manage the skin conditions around it so that the bile or the feces does not exteriorize, spoil the quality of the skin around it, and take care of it. Most of the fistulas, you'll realize that they don't go into sepsis because there's already an outlet. It is only contained intra-abdominal leaks and infections that usually deteriorate. Biliary sepsis is horrible. It probably ranks in my mind a little higher than even fecal sepsis. Yeah, they are notorious and they take our patients down. So a very, very early management of these biliary leaks is very, very vital. Endoscopic options are available. Uh, then radiological options are available. So if there is, for example, I will tell you, if there is a leak from a bariatric procedure, if there is a stomach leak, and it's just forming a perigastric abscess, you can drain it intragastric, just like we drain
Yeah.
pseudocysts of the pancreas by endoscopic options. So you have a very, very safe method of draining it. If the patient is in diffuse sepsis, then a diagnostic laparoscopy, if you have the skill sets, or an exploration will benefit. Most important thing is improve feeding. So either increase feeding by a nasojejunal tube or do a feeding jejunostomy along with whatever drainage procedure you're doing. Because if nutritional refeeding is not started soon, most of these patients will deteriorate. That's my take.
That's very well summarized. I'm sure you've covered quite a few of the leak management. In fact, bowel, biliary, and urinary. Catch it early and act on it early rather than letting it manifest. And now coming up with the endoscopic management of these leaks. So that's pretty well summarized. In the interest of time, I'm a little running ahead with questions. Dr. Saumil, if you could take up this IV fluid management in the post-operative phase. Normovolemic, high crystalloids, colloids, what is your take?
Yeah, I think there used to be a time when patients were given fluids very liberally. I think the thinking has changed now. You just give just enough fluids. Fundamentally, the idea is not to overload the patient. You keep them euvolumic or even mildly negative because that reduces the bowel edema. It prevents third spacing, which ultimately leads to better patient performance in the immediate post-operative period, meaning there is a decreased preload, the heart functions better, you have reduced incidences of pleural effusion, third spacing, bowel edema, and then you obviously have your anastomosis working quicker, which leads to early resumption of feeds. And this is a paradigm shift that has happened over the last couple of years, that where you do not give too much fluids either intraoperatively or perioperatively. You basically take a very controlled decision based on the patient hemodynamics, urine output, the underlying urea, creatinine values, and appropriately manage these patients. In general, you could basically target a urine output of about 0.5 to 0.6 ml a kilo body weight every hour. In fact, there has been a recent publication where even if you had an urine output of 0.3 ml a kg body weight hour in an otherwise okay patient, you don't need to push up or give extra fluids or colloids to boost up the urine output.
Yeah,
So that much fluid should be okay. Number two is with respect to transfusion, do not transfuse unless you have to. A cutoff of about 7 gram% of hemoglobin should be okay unless there is a bleeding or a hemodynamic instability. Otherwise, in most instances, after major visceral surgery, you would avoid immediate blood transfusions also, as far as possible.
That's very well summarized. I nailed it. In fact, I put it that way. IV fluids, the trend has changed a lot. Rather than giving a fixed rate, it's kind of measured and kept little negative than normal. That enhances again early recovery. Goal-directed fluid therapy, an important component of ERAS. Pain management protocol. For Dr. Saumil, for your open surgeries, abdomen surgeries, what is your normal protocol for pain management?
So we have our anesthetists put in a epidural. That's the norm. A combination of bupivacaine along with an opiate generally is given through the epidural, or bupivacaine or ropivacaine alone. The rate is titrated depending on the pain threshold and also its effect on the hemodynamics, particularly with blood pressure, etc. And then this is supplemented with regular IV paracetamol. And in most instances, one finds that the patient is able to manage the pain reasonably well. We would normally keep the epidural in for about 3 to 4 days and then slowly phase out the epidural before eventually removing it in 3-4 days time. I think the most difficulty that we face is within the first 24 to 48 hours, when the effect of the general anesthetic is wearing out, especially if patients have been ventilated overnight and they suddenly then, as they get extubated, the pain is quite significant. And I don't think the pain is too much, but it's just the perception of the pain that becomes exemplified, because as they wake up from the anesthesia and get extubated. But generally, this is quite, it is okay to manage, and we can manage this very effectively with a dedicated pain management team who is able to manage the epidural quite well.
So coming to this epidural with bupropion with fentanyl, opioid base of fentanyl, I have a kind of always have a constant discussion with my intensivist. How is the influence of fentanyl on paralytic ileus when it goes to an epidural as compared to IV fentanyl? Have you
Yeah,
had
I
any trouble
do.
with that?
Yes. I think the adding an opiate in any form, whether it's transdermal, whether it's through a patient-controlled analgesia, or whether it is through epidural, it slows down the patient in general. I mean, the patient does experience a little bit of sedation, drowsiness. It's difficult to mobilize, get them to do spirometry, chest physiotherapy, and generally it also has its side effects on bowel function directly, as well as a result of overall slowing down of the patient. So I
Yeah,
think it is it
this is
relying
something that
on
I
yeah.
yeah. Now, this is where I think we need to kind of make up a study saying that
Yeah.
epidural with and without fentanyl, and come out with our data and see how's the outcome with it.
Yeah, I think that's a good point. We should have some standardization and actually have a head-to-head comparison, because if we find that the epidural is doing more harm or slowing down the patient rather than relieving the pain, then we could withdraw that
Yeah,
and do away with it. Yes.
sure.
But isn't it a
DVT
known fact? Sorry to jump in. Sorry to
Yes,
jump
please.
in. Isn't it a known fact that the opioids anyways are going to slow down the smooth muscle movement? Because in Western world or in overseas, of course, it's not available here. The first choice of drug in renal colic is morphine. And that definitely, because it slows down the ureteric peristalsis and it takes away the pain in no way. So that's, I think it's even we can extrapolate that to your bowel movement. So
Agreed.
I think we should
Yeah.
stay away from that.
Coming to the last question for this, can each one of us take it one after the other? So, Dr. Lakrawala, starting from you, DVT prophylaxis in the post-operative period. When and what do you start? Dr. Santoshi, you want to take it in the meantime?
Yeah. So the key factor I would say here is three things: early ambulation, early ambulation, early ambulation. That is one thing I strongly believe into. So the next day, the patient is should be up and about, regardless what kind of surgery he has had. And at least I can apply that for urology very well. We, if it is a prolonged surgery, of course, the SCDs, the sequential compressive devices, they are used in the ICU and even in the post-operative period until the patient is ambulant. Unfortunately, we haven't been following TED stockings here. I have been insisting in our theater, but probably the cost factor is one thing. Thankfully, we haven't been seeing too many patients with DVT, though we do handle a lot of oncological cases. But the high-risk patients, yes, those who are on blood thinners or previous history of DVT, we have to be extra careful. Robotic especially, we are worried because they are in Trendelenburg position for prolonged time. And that is like at least 20 degrees head low, which does increase the possibility of DVT in them. But we make sure that their legs are not really above the level of their hip joint. So we try to bring them down a little bit. So I particularly don't follow any strong protocol in post-operative period to give them heparin or low molecular weight heparin unless we know that, or we anticipate that the patient is not going to be on his or her feet for a long period of time. Or if it is an extensive surgery like cystectomy with evisceration or previously treated with chemotherapy or radiation therapy. So high-risk patients, I will reserve low molecular weight heparin. But otherwise, I generally manage them with SCDs and early ambulation, if that helps.
That's right. Yeah. Dr. Lakdawala, DVT prophylaxis, pharmacological plus minus mechanical. What is your take?
So all our patients get perioperative DVT prophylaxis. Yeah, we are in the highest risk group, especially those patients who are on oral contraceptive pills who've had probably previous history, and almost every patient with a BMI of above 35 gets at least 6 hours prior. So our protocol is very clear that if they have an EGFR which is above 65, then they probably will get a low molecular weight heparin. If they have an EGFR which is less than 65, then we would recommend only heparin and not low molecular weight heparin. Okay.
Yeah.
Now heparin is given in the patients with a BMI of above 50. We give it in a BD dose, 12 hourly, 5,000 international units substitute. And anyone with a weight of above 125 kilos, again, is recommended heparin. Because according to the product monograph written by the companies themselves, there is no time-tested proven study to prove the efficacy of low molecular heparin in a weight above 125 kilos. Now, all our patients are mobilized very, very early. We give them good hydration perioperatively. They get mechanical stockings as well as cuff pumps intra-op as well as post-op. We prefer to mobilize our patients within 4 hours of surgery. That kind of helps reduce the surgical times because, like I said, we are in the highest risk group of patients having a propensity to develop DVT. Those patients who've had a previous history of DVT, now it is slightly controversial whether to put in a filter or not, an IVC filter. Because results and studies have proven that whether you put in a perioperative IVC filter with or without, the mortality rates remain the same, and the chances are. So once you put in an IVC filter, to remove it again is a bigger problem. Yeah. So if you have good medical management of this, then it's good enough. Now, post-operatively, most of our patients go home again. The idea is whether you put them on any other drug other than an injectable drug like dabigatran, oral this thing. Well, we tried our hands with oral preparations for prophylaxis and prevention of DVT in the post-operative period. But unfortunately, we had a few cases in which there was reactionary bleed. Yeah. So we've given up that now. So others might still be following it. We follow a protocol of sending our patients home on 0.6 of low molecular weight heparin or 60 milligrams or 0.6, whichever you want to call it, once a day. BD if they are above a BMI of 50. And most importantly, that they go home with good hydration, and at least if they are above 50 BMI for at least 15 days post-op, they continue to take this unless they have any bleeding in stools or they're vomiting blood or something of that sort. Paresh?
Perfect. That really answers it well. Soumil, your take on open surgeries, do you start within 48 hours or after 48 hours?
Yeah, so we would give thromboprophylaxis to every patient who undergoes major visceral cancer resection, particularly so after an open operation or pelvic surgery, something like that. The answer would be we would commence with anticoagulation the next day within 24 hours. You look at the coagulation parameters, drains, hemoglobin, and the overall performance of the patient to make sure there is no bleeding as such or drop of hemoglobin. One thing that I personally follow is look at the INR the next day, and if the INR is less than 1.5, I would consider it safe to commence anticoagulation, which usually is either with enoxaparin or dalteparin, low molecular weight heparin, unless there is a renal issue which then compels the use of unfractionated heparin. And generally, I would give it at a rate of about 0.1 milligram a kg body weight. When it comes to enoxaparin, or which is Clexane, if you used dalteparin fragment, then one would give it at a dose of about 100 units a kg body weight every day. And of course, if the patient has had previous history of DVT, then one would use slightly enhanced doses, either 150 units every day, 150 units of fragment every day, or 0.1 milliliters of Clexane in 2 divided doses. But yeah, I think most guidelines do suggest pharmacotherapy as well as mechanical devices for the prevention of DVT. This is not a substitute for early mobilization and physiotherapy, etc., which will continue regardless.
Perfect. That's very well said. So just couple of
So-
things which supports everything. We are on guidelines with what we are practicing. That again, it's an evidence-based practice. Again, the latest articles 2023, which supports what Dr. Lakrawala and team supported for the bariatric surgery. Again, the role of venous thromboembolism in hospitalized patients. Again, pretty well supported by all the three panelists. An important thing, just to throw a light, what I read during this presentation was for prostatic surgeries, they normally don't give, it's contraindicated, in fact, giving pharmacological prophylaxis. So that's one thing which is something new I learned. And yeah, they're planning to implement ERAS in emergency general surgery as well. And again, it's a big study coming from Italy. Something what I guess we need to look into it, because as of now, we've all been using ERAS for elective surgery. According to this surgery, they want to implement it for emergency as well, where they're proven it to be feasible. So probably the next thing what we are looking at it now. And it should show an improved outcome and recovery from that. So again, the best way to do is audit ourselves so that we know where we are going and which direction is the best way to go ahead. So always maintain an audit cycle and then implement the change. Thank you.